Perfect timing, because I have 3 leaders joining me today. We were asked to do a health center highlight. CHC was asked to recommend someone, and I tried my best, but all I can think about is those leaders that I know that, Dr. Alley kept saying vulnerable, and I kept thinking about our leaders. I always say ours are authentic, and they're honest, and they are true to who they are. And you said a lot of things today, and I swear we didn't plan this transition, but I wrote down a lot of notes: modeling the team cohesion, leaders who are champions. This is 100% the leaders that I brought to the table today. Before I share the slides, I'd just like to introduce Dr. Blankson, Dr. Kearney, and Dr. Channamsetty, who are all our chiefs of behavioral, medical, and nursing. We do have dental. Sheila's not with us today. We only have 30 minutes. So I'm going to do a quick introduction, and then I'm handing it off to them because they have a lot to share today. But I thank them for joining. I know that it is, and as always, the introduction slide. Can you all see the slides in front of me? I don't see any head shaking.
Yes.
Perfect. Thank you, Gerard. So you may have joined the Chiefs in previous sessions. They actually were doing an adapted slide set of this, and it is a 90-minute presentation. And today they worked really hard to really condense it down. So very quickly, as I said, these are their titles as well as their names for reference. But today is really about best practices in delivering team-based care in a telehealth care environment. So Community Health Center, Inc., it is a statewide organization in Connecticut. It provides comprehensive primary care, as I said, dental, medical, behavioral health, and now telehealth. We were founded in 1972, and really just some important components of our model: fully integrated teams and data, integration of key populations, data-driven performance, as well as school-based health centers, wherever you are, clinics, and urgent care. A lot of you may have joined the Weitzman Institute, Training and Technical Assistance. That is the research arm of the organization, which also off of it has multiple subsidiaries: the consortium, NEMA, and ConferMed, all organizations that you may have actually interacted with or have heard speak before. We will have the CEO of NEMA actually joining us tomorrow. So lots of information here, and you can reach out to me about this as well. And then just continuing forward, this is another really important piece of what our work is. We do, obviously, as I said, statewide comprehensive primary care organization, but those subsidiaries and the Weitzman Institutes has a national reach and a national lens to the work that it does on top of our National Institute of specifically training and technical assistance, training the next generation, team-based care, a lot of fruitful and helpful information, and you may have engaged with during the pandemic and continue to engage with as we move forward, whatever that may be. And what are our objectives today? 2, because we only have 30 minutes, but discuss the evolution of care teams and then provide a discussion around the vision for what the future may look like. And I am excited to hand it off to the Chiefs and get it started today.
Great, thanks, Amanda. As Amanda mentioned, I'm Tim Kearney. I'm a clinical psychologist, the Chief Behavioral Health Officer. And I wanted to start with just a few minutes about what our pre-COVID landscape looked like and what we wanted to keep and the challenges before us. As Amanda mentioned, we're really dedicated to 3 specific pillars: outstanding clinical service, research and development, and training the next generation. And prior to COVID, all of our clinical services, which are all delivered in Connecticut, were delivered face-to-face on site. Connecticut had mandated that private insurances cover video telehealth, but not Medicaid, not Medicare. So we had a very small trial in behavioral health, just beginning. I think we had 4 staff beginning to be up and running, doing telehealth out of our 215 or so behavioral health providers. We had a graduate professional education grant for training psychology students, which included telehealth development. How were we going to train students in telehealth, that was year 1 of our grant. And we had just begun thinking about how we were going to do that and getting the students' toes a little bit wet. Although we had some experience doing asynchronous electronic clinical care through some of the programs through Weitzman that Amanda had already mentioned, we felt like we were beginning to get ready. We knew there was a revolution coming. We just didn't know how fast. And we did, because we're a statewide organization, we were somewhat poised. All of our staff knew Zoom. We're using Zoom already for administrative meetings. And as I mentioned, we've been doing a lot of training through Weitzman, both synchronous and asynchronous. So there was a lot of our staff that had familiarity with getting on a screen and seeing all those boxes. Our student training was almost entirely face-to-face. We did have e-supervision in our postdoctoral residency program because our residents might be seeing patients on one site on a given day that their supervisor was on a different site, but they had supervision scheduled that day. So there was some facility in doing some supervision remotely, and we had experienced remote hosting some of our residency programs. But that was really where we were when the pandemic hit. And like all of you, we went from 0 to 100 in about a day and a half. So Venna, why don't you tell us more about that?
Thanks so much, Tim. And as Amanda and Tim said, my name is Gina Channamsetty. I'm the Chief Medical Officer for CHC. I'm a family physician by training. So yeah, as Tim brought us back, it's worth just taking a second kind of to think back mid-March 2020 on the East Coast. Our state went into full shelter in place. And so we quickly saw that our current delivery care model wasn't going to serve our patients or our communities. But we also realized very quickly that our healthcare needs for our patients didn't change. So really our mission was to immediately stand up within days, a way to continue delivering care and keep offering continuity of care, but also offer care to new patients still seeking it. So really what we did is we specifically looked at our existing infrastructure and culture. What do we already have in place that we can build from? What do we need to rapidly implement to meet these care gaps and operational needs that this public health emergency had created? And then of course, what reports and data did we need to continually monitor and refine all these changes we're making? So even though those 3 steps were a year ago, even today, we use those exact 3 steps because the country's opening back up and we continue to ask ourselves, where are we now? What changes do we need to make to meet these gaps that are occurring in the landscape, and how are we going to monitor and improve? So next slide, Amanda. A good way to really do that is to use a tool which I'm sure most are very familiar with, the SWOT analysis, and that's what we did. So early on in the pandemic, as you can see, we identified more weaknesses and threats than strengths. And that's really okay. We were in a changing environment as we are now, and we knew we would have a lot of work to do. We had some foundational strengths, and with very engaged leadership. We had, Tim mentioned, we had strong and centralized IT and business intelligence team. We had wonderful mission-oriented staff. But suddenly when we kind of looked at our weaknesses and threats, we knew we had so much to build on. Tim already talked about where we were with telehealth. We had one small pilot in behavioral health, but no sustainable telehealth platform or workflows or procedures in place. Our care delivery and business model heavily relied on fee-for-service and in-person visits, and our team-based model relied on the teams being co-located on site in pods, which obviously wasn't going to be realistic when staff and patients are virtual. So the reality is that these weaknesses really are opportunities for us, right? So for us, it was an opportunity to build a full telehealth model of care delivery and actually re-choreograph what team-based care looks like when it's a virtual team. And we, to this day, continue to plan around this. Telehealth has become a very realistic and even an expected option for our patients. And specific to workforce, this was also an opportunity to possibly support the retention of our staff by offering flexibility of remote work, which we'll actually talk about later. So the take-home message really is that weaknesses and threats may be large in a time of emergency, and they'll continue to be present as the landscape keeps changing on us. But by using a tool like the SWOT analysis and identifying them proactively, you'll be able to plan proactively as well. So next slide. So the next step, and which will be the bulk of our presentation today, is rapid implementation. We're going to look at what we had to rapidly implement and improve on, utilizing all our teams in an innovative way. This consisted of early regulatory advocacy, which I think everybody's familiar with. It was regular calls that continue to this day with our state offices, our Medicaid agencies, to ask for and advocate for regulatory relief, which, as we all know, has come and continues. Quickly mobilizing staff and patients so everyone understands the larger plan and their specific role in it. The redeployment of staff to support the larger efforts and success of the agency. It's worth saying from day one, early on, CHC very early committed to no layoffs and no furloughs. And we kept that promise. And really with the pandemic, there came such a high need to support COVID efforts at all our sites in our communities that we really have all our staff in a role that really meets the needs to make that successful. We'll also talk about implementing initiatives to make sure that we're continuing care, updating the way we are reached out to our patients, and communicating. So let me hand this off to Mary, and we'll get us started on this rapid implementation section.
Great, thank you so much, Venna. Communication definitely is by far the most important key component in creating rapid change. So the first and most important step is making sure that you have quick and real-time communication, and making sure that you're communicating in every way possible. We had an email line where people could send in any question. We called it chcvirus@chc1.com. So anyone could send in a question, a concern, that was sent there. We would respond, and then oftentimes actually collate those answers and then send them out via general distribution. So there was email communication. There were trainings that were scheduled during lunch or in the morning to get everybody set and ready to go. We created nuggets and other types of sort of 1 or 2 pagers that had step-by-step instructions, but making sure that everybody had everything documented and communicated as often as possible. We recorded everything also just to make sure that if somebody was missed, we had the ability to pass that on. Transparency of mission and strategy was also very important. I think Venna highlighted very well that we committed early on to no layoffs and no furloughs, and that was a message that we shared very early on with our organization and all of our employees. But in order to do that, we also made it very clear to them that we had to make a very successful, quick pivot to being able to successfully delivering on a business model that we were not yet settled or had actually effectively created and implemented. So that really was to garner their commitment as a member of sort of the CHC family and of our organization to commit to success. We gave a lot of ongoing reassurance along the way. So several of those messages, we again continued to say them. Those were our mantras. We are committing to no furloughs, no layoffs. We are here is the new information that is coming from CDC. I know Venna, myself, and others probably spent every single day, a portion of our day, looking at the CDC website for new information and new things that were coming down the pike, so that our staff heard it from us before they even noticed it, so they could feel calm and less anxious and actually feel like they trusted our clinical leadership, that we were on top of things and always looking for what was coming next down the pike and supporting them to be prepared for it. Frontline meetings were extremely important. We had town halls that were taking place at least every other week at the very beginning, and then sort of monthly thereafter for all of our employees to keep them on the same page, as well as individual meetings, meeting with our leaders. I met weekly, sometimes actually every other day, with our nurse managers at the beginning, Venna with her on-site medical directors, Tim with the on-site behavioral health directors, to make sure that all of our sites across the organization were on the same page, and that all of our sites had that individual touch that they needed. School-based staff were going through different things than our main site staff, and they were going through different things than maybe at our shelter sites or at some of our other mobile programs. We also then, the last step, redefined our incentives for productivity for medical behavioral health, and actually added a specific incentive to nursing for a 3-week period of time to support the rapid pivot to telehealth. And that included making sure that if they would hit certain numbers or make sure that they could support patients to actively engage in telehealth, that there was a financial incentive to support them to do that. Again, making sure that all of our staff were sort of rowing in the same direction as a team. Next slide. So then we had to consider our infrastructure. So we worked with IT and we identified that Zoom was probably going to be the best platform for us to use, because we used that for all of our internal meetings and everyone was very familiar with it. As Venna pointed out in our SWOT analysis, using tools that the teams already had some training in and already had some familiarity led to better success in adopting additional technology related to that platform. So we were able to add Zoom phones. We were able to add Zoom video, which allowed for the medical assistants to create an unlimited number of exam rooms for any patients that were there being seen via video, and also met all of the HIPAA standards that we needed for our patients. With that implementation, again, we created a series of nuggets and did a series of trainings for all of our staff to roll that out. Behavioral health actually was the leaders in that, again, as Tim had pointed out, that we had already started with behavioral health, building that infrastructure, but medical very quickly, in a matter of 1 to 2 days, actually turned around nuggets and instructions that we needed for our teams to be able to begin delivering medical and nursing care via video and via telephonic care. We also built a series of electronic health record templates to make sure, again, that all of the requirements as they were coming out, whether it was measuring the time that the telephonic or televideo visits were taking place, the specific coding, all of our consent templates and language, all of that was programmed into this template to make it so much easier for our clinical teams to make sure that that communication was not only delivered to the patient, but also effectively documented as a part of the progress note. Again, our HIT teams worked overtime, really working with us, editing, adding new things to make sure that our health record could really support this quick transition. Next slide. Lastly, I just want to talk for a minute about teleteam-based care and kind of the virtual team, as even our medical assistants and nurses were all working from home for a period of time, and very small teams were actually still on site. So it was very important for us to support them to be able to understand what does their model of care look like when they're rooming a patient virtually via telephone or rooming a patient virtually via the video. What are the steps? What are the planned care items that they can still accomplish for the patient? What additional things do they need to communicate as a part of sort of telehealth concierge, so to speak? What we noticed very quickly was that our provider and medical assistant dyads sort of broke away from the rest of the team a little bit, so that they were really the two working together as a team in tandem, the medical assistant creating the exam spaces in Zoom, rooming the patients, preparing them for the provider, and then the provider going into the room to be with the patient. Sorry, go back a slide, Amanda, thank you. So, and then the nurses actually sort of broke off from the clinical team in the sense that they were not just sort of sitting in the quote unquote virtual exam space with the provider and the medical assistant, but they had their own visits that they were accomplishing with patients. So they had their own telephonic visits that were happening. They were doing the bulk of our triage, the bulk of COVID. So much of what was happening in terms of that incident to handoff for education was actually happening sort of asynchronously, so that the idea of sort of these independent nursing visits via standing and delegated order became much more important for our patients. So that kind of gives you a little bit of a look at sort of what the telehealth rollout looked like. And of course, we had other virtual team members as well with our registered dietitians, our medication-assisted treatment providers. So we really had to consider not just what does medical care delivery look like, but what do all the various different components, podiatry, dietitians, and really take each one of those examples separately. I know, Venna, you have more to share on this, so I'll turn it back to you.
Yeah, thanks, Mary. And right, I think that's a great point, right? So to really think about and to be able to continue the integrated care we had pre-pandemic, really had to think about what now the team-based care looked like. So we had kind of on-site team-based care that now was becoming tele-team-based care or virtual team-based care, which is now further down today, let's say, becoming a hybrid of both. So it's really important that we understand that there will always be some part of our care model that's going to probably be virtual going forward. It's really how much is on site and how much is virtual that will change over time. And it's something really key to think about as you think about staffing, patient care, scheduling. A key point that everybody should understand as you think about this is that in this new vision for integrated care, meaning that all care members are part of the patient-centered medical home, but some of those team members will now be virtual team members, but still available to patients that they always been. So the collaboration and handoff between team members will really need to have a defined procedure. And the collaboration itself may actually be virtual, where at one point you were looking over to behavioral health next to you, or another team member that might have been sitting next to you or one office away. You now have to think of that as a link away or a system communication away or a call away. So a key example of that, of course, is behavioral health. Pre-pandemic at CHC, medical and behavioral health were co-located in every pod together. And when we needed a patient seen between the two or had a shared patient, there was an actual physical warm handoff between providers and the patient. Now with virtual care, that looks a little different. So Tim, I know you will talk about what your thoughts are on what happens when there is a virtual team member.
Tim, you're muted.
Of course I am, and you would think by now I would learn not to do that. So thank you. So typically the initiation of a new behavioral health patient comes from our medical provider colleagues. And as Venna said, our model has historically been in the same hallway, right next door to each other, sitting next to each other in the pod. And so we would simply walk into the room, meet the patient. That wasn't going to happen. And the need for behavioral health just skyrocketed at the time that the pandemic hit, with everybody closing down, especially with children and adolescents, which is my specialty. So we made some changes in our templates, one of which was to set it up so that every medical patient was asked in every visit, would you like to talk to a behavioral health person? Do you feel like you need to do that right now? So that we could catch that need that might otherwise not have been brought forward by the patient. Next slide, please. And so building that into the electronic behavioral health warm handoff, the EHU, we built it into the medical patient. We did a shift so that initially all of our behavioral health visits were going to be 20 minutes. And we did that for about 2 months before we were able to really manage the need better and bring us back down to our usual 35 and eventually 40-minute visits. We had all of our school-based staff available. We have about 100, a little over 100 clinicians in schools doing behavioral health at clinics that are located in the schools, and all the schools were shut down. And so we were able to bring them in to help us with not only the kids that they had been seeing at school, but this tremendous influx of new patients. And what we discovered, and this has turned out to be a benefit of the new system that continues to this date, is geography was much less important as compared to need. In the old days, if you were in a particular city, say Danbury, you saw a member of the Danbury staff, and that's how it worked. But now if you're anywhere in the state of Connecticut, we can have one of our staff who specialize in a particular area, or we can stand up a group with 2 people from this site and 4 people from that site and a 3rd person from the other site. So we got some new opportunities that came along also. And of course, we have made a point of tracking need and utilization, because that's how we know from day to day and week to week what we need to change. And not only did we have to continue the ongoing care, the initiating new care, we had to have continued care as well. And so how were we going to take care of established patients? And we did that by, as I said before, going totally remotely, doing initial assessments of new patients. The warm handoff is a quick 30-minute assessment. Is someone safe? Is someone healthy? Can we keep going forward with behavioral health work? And then we would do a full assessment of the new person remotely, continue our medication-assisted treatment, do the initiation and get folks up and running with that remotely, and began to get groups back up and running. That has been and continues to be a challenge, although on an ongoing basis now, with a system that we put in place to be able to refer from one site to another, our group program is growing and really helping us manage the need. And all of those school-based people who came in to help us at the end of the year, their time was up for the summer, and we would have to figure out how to transfer them back. So lots of ongoing things, but also lots of opportunities to learn and think through questions that enable us to be nimble as we go forward. Venna.
Great. Thanks, Tim. So, it is important as we are with all these FAST initiatives to just stop and take a look and ask, are our efforts working? Are they successful from an access standpoint, which Tim just talked about, from a business standpoint? And so it was with relief that we could see that by the end of that first month, we had returned to 96% of our pre-COVID visit level. And over time, actually, we saw the behavioral health was actually seeing more patients virtually than they were even budgeted for. And then we've been really able to maintain close to or above budgeted levels of visits going forward, being able to quickly implement options like telehealth in addition to in-person visits. Next slide. So to that point, it really brings us to refining the process. So post rapid implementation, we really have to think about refining it, right? It's important to remember that you're putting a lot of changes into place during an urgency of an emergency, but those might not be ideal over time. So every day, literally every day, we assess the current state of performance. We leveraged our business intelligence team. We created multiple data reports and really took a data-driven approach to really further support process changes, patient outreach efforts, and other clinical care delivery needs. As Mary mentioned, we also spent a lot of time listening closely to our frontline teams and staff and their challenges. As we know, everything will not be captured in a data report. And so a lot of our refinements and changes to process came directly based on their feedback. And we found that this was a key important fact to our workforce. They know that we can't fix everything, but over time, our teams knew that we'll continue to listen, which has really helped to build trust and resiliency within our teams. Next slide. So a little more about refinement and what kind of data we're collecting. It's very important to keep an eye, in addition to our workforce, but also on our patients' concern and patient satisfaction. Ask the question, did patients even like telehealth? Did they want to continue telehealth? Very early on, we wanted a way that patients could share real time with us their feedback on their experience with telehealth appointments. So back then, we did a very quick SurveyMonkey questionnaire via text message that was sent on the same day of a telehealth appointment. These are 4 questions that were asked of the patients of their experience. Overall, we saw that patients receiving video visits were sharing that they were very satisfied with the Zoom audio and video quality and overall quality of care they received, and that over 84% were interested in continuing to receive their care via telehealth. So that was a key data marker that we used in some of the steps going forward when we talk about refining. Next slide. Additionally, agency-wide for years now, we use a company called the Crossroad Groups to survey our patients on their full healthcare experience. Post-COVID, Crossroads actually modified their usual standard questionnaire to include questions on satisfaction with telephone and video services. So while the text survey I showed you in the previous slide was information very early in the pandemic in 2020, what this slide is showing you now is literally the most recent patient satisfaction data we have, and this is from the first quarter of 2021. So very interestingly, what we are seeing is that patients who receive video services, which is the pink line, are mostly highly satisfied in almost all metrics. Telephone services, which is the blue teal line, have a lower satisfaction rate, and the in-person visits, the black line, rate somewhere in between. This is kind of key in knowing what to focus on for options of care delivery as we really plan out our next steps over the summer and onward. So to that point, I'm going to hand it off to Mary so she can talk a little bit about our workforce in all of this.
Great, thank you so much, Venna. And really, I think as we look forward now, we are looking at a lot of our options around some folks being back fully on site. Currently right now, for example, 100% of our medical staff and our nurses are back on site, except for our telephonic triage nurses, who are now also fully remote, along with the rest of our call center, working from their homes, set up fully remotely. So now, particularly for us in the Northeast, even if we have a snowstorm or other things, they can quickly respond to coming to work and still receive phone calls as expected. We have also some folks who are choosing sort of a hybrid approach with some on-site time and some remote time. This is definitely looking a little bit different based on department. And then lastly, sort of the creation of what we call telehealth pods, which is for individuals who maybe don't necessarily have the best Wi-Fi at their house or don't have a home situation that is really fit for them to be able to work remotely and to be able to focus on their work. So some people have actually chosen and said, I really want a workspace, but we have said we don't necessarily want to take up room in the clinical area. So we created telehealth pods where folks can report, have their double screens, be able to plug in their laptop and have kind of this cubicle space that's set up to support them to deliver their telehealth visits right there from their, from the privacy of their own sort of mini office in the telehealth pod. The last thing that we've also done is to actually create opportunities for patients maybe who want to participate in telehealth care, but don't necessarily have a safe space to do that with privacy. So for a patient to actually present to a clinical site and to be placed in an exam room with an iPad or with a laptop to be able to then have a telehealth visit with their provider, particularly if it's behavioral health and they need a more private setting to have some of those conversations. Next slide. Of course, there's a ton more work for us to do. And as Venna said, every single day we are doing something. And I think right now we're going through a lot of our policy updates and things that maybe we solidified in sort of a procedure, but never actually wrote the policy portion of it, just to make sure that we have all of the logistics the way that they need to be. All of our supporting policies in place. Are there any pieces of our infrastructure that we don't love, or systems that maybe we need to consider replacing because we didn't love, the first model that we've gone to? Of course, continuing communication all along the way with all of this, and really moving towards just a new conceptual model of what does our model of care look like. I think our organization, we are very, very clear with everyone that this is our model of care. And if you're coming to work for CHC, this is the model that you're engaging in. But because this model has shifted, I think all of us as clinical chiefs are really trying to solidify and document exactly what we're calling our new model of care. What are the nuances of it that maybe we're still trying to work out and determine and refine along the way. Next slide.
So a little bit about in-person. I won't spend too much time on this. I know we're low on time, but I will just say that, a question that we are asking ourselves regularly, and certainly now, is which visit, right? When is in-person appropriate and when is telehealth appropriate? And how do we put those procedures in place? On the slide now, you'll get a sense of the procedure around in-person visits we've had in place during the pandemic, as really most of our visits actually defaulted to telehealth, not in person. As the country and the state opens up, we are moving back towards defaulting towards in-person. And what that really says looking forward is that we know our patients need the option for both virtual and in-person care, but we also know that our providers would benefit from the benefit of having both in-person work and virtual work, and really have a hybrid of a workforce. It is important to note that this might look different among disciplines, and Tim, it might look very different in behavioral health versus medical.
Yeah, I think the questions are the same questions. The answers may be a little bit different. We don't have quite as much of a need to be back on site to do a lot of the work that we do. Many of our patients are telling us they don't want to come back on site. And we've just begun now to bring some of our providers back into the clinics alongside the medical. There's clearly benefits to doing that, but our anticipation is that our program will be hybrid going forward. And I will leave it at that and pass this back to Mary.
Great. So I think sort of one of the final thoughts we will leave you with is just this idea of thinking about a dimmer switch approach to different types of care, telehealth versus in-person, and all of those things. We want to think of our model of care as something that we can sort of change the dimmer switch. We can turn it up and make it brighter. We can turn it down and make it a little bit dimmer and do more telehealth based on whatever's happening in our world, based on regulation changes, reimbursement changes, as well as kind of what's happening with COVID-19 or potentially any other pandemic or disaster or other thing that may actually come along. So making sure that our teams know and understand that this dimmer switch can move at any time, and that we have all of the pieces in place to know what to do when we have to change the position of that dimmer switch. So I think sometimes sharing those types of concepts with your teams really helps them to maintain their flexibility, particularly in an ever-changing environment. Next slide.
And just to say briefly, same goes with students. We were able to keep our student programs going with some differentiation according to different disciplines, and are looking at a hybrid program coming in the future year, and we'd be glad to answer questions about that offline if people have any. Next slide.
And this is just a summary slide. I think it, I won't go over it in detail, but it just really does kind of note what we really have found to be our best practices in this long road that has been lots of pivots. Certainly making sure you understand the current state, feedback from your staff, really look at your staff and how they can be really utilized in innovative and new ways, communicate, and really embed streamlined procedures and defined policies and procedures, so everyone is clear on the expectation of their roles and how to do what might be a new role for them.
All right. Thank you so much. I have to say thank you for making a 90-minute presentation into 30 minutes and doing it perfectly. I'm actually thoroughly impressed. But I really want to stress that a lot of you have joined the Chiefs, CHC, you know, the national conversation at the Weitzman Institute with the COVID-19 echoes on this conversation. I watched the Chiefs and Margaret Flinter actively do these remarkable things and then share it then within 3 days. And I know that we hope to continue those conversations as we head and move forward. So remember the Project Echo, think about training programs, telehealth, confirm med, really just see the breadth of the colors that are on the screen with the logos and know that these organizations are here. And I hope to continue to bring the Chiefs to the table to keep the conversation going. But I know we're over a couple minutes, but I really thank all three of you for joining today. And it's exciting. Now hand it off.